Hello. Welcome, welcome, welcome. We will give folks a second to join us in the video. We know folks are joining from Facebook. We know folks are joining from YouTube. We know folks are joining from Twitter. Welcome to this week's mass call, to this emergency call. Want to ask you to go ahead and drop in the chat. Tell us your name. Tell us where you're from. And just to let you know up front, that we do remove folks if you are being trollish in the chat. We want you for now to just introduce yourself. We want to know who you are. We want to know where you're joining us from, and we want to know what brought you to this call today. So please let us know, what brought you here. For those of you who are joining us for the first time, maybe, or haven't joined us in a while, I am Tamika Middleton. I am the Chief Political and Strategy Officer here at Women's March. And I am joining from Atlanta, Georgia. I can't tell. I think my screen might be a little bit, my service might be a little bit glitchy. So apologies if I am going in and out. I'm not sure what's happening with my internet right now. But again, joining you all from Atlanta, Georgia. Always very grateful to be here with our Women's March family. And as folks join us, continue to introduce yourself to us in the chat, introduce yourself to each other. As you may know, if you need captions on this call, we ask you to hop on over to our Facebook page. That is where we have live captioning available. YouTube does not currently support the live captioning. However, there will be captions on YouTube on the replay video. But if you are joining us live, jump on over to our Facebook page to watch this with captions. Some baseline agreements. We are grateful for everyone to be here. We want this to be a welcoming space. We want this to be a space where people can learn together and build together. And in order to do that, we want to create a space that is welcoming for all of us. And so if we see you being trollish, if we see you being disrespectful, we will not hesitate to ban you from this chat. We are folks who join us before know we like to say that our ban hand is very strong. So we ask you to be coming into this space in the spirit of love, in the spirit of growth, in the spirit of community, in the spirit of building the kind of world that we want to see. And so we want to practice that in the comments here. So thank y'all so much. Again, if you're just joining, my name is Tamika Middleton. I'm the Chief Political and Strategy Officer here at Women's March. I think we're also dropped the working agreements link in the chat. So if you are new to us, you can get a sense of what etiquette looks like and what etiquette means for us inside of this space. Please use the chat function to ask questions, and we will answer as many questions as we can. And especially, I will introduce all of our guests, but if you have questions for the Congresswoman Robin Kelly, go ahead and start dropping those because she will have to leave earlier in the program. So we'll ask her questions immediately after her presentation. So thank y'all so much. I see folks joining us from Pennsylvania, from Oklahoma, from Philly, from West Texas, from California, Oregon, so many places. Thank y'all all so much. Oh, yes. Come on, nurses. A few nurses in the chat. I love that. Thank y'all for joining us. So I want to just give us a quick grounding in why we are here. I want to say up front that here at Women's March, although we are broadly a feminist organization, and in particular, our feminist politic is informed by our Black feminist elders, especially those like Barbara Smith, those like Bell Hooks, and so on. And so, and also by our Black feminist elders like Loretta Ross and those folks who founded the reproductive justice movement. And those are folks who very much shaped me and very much shaped my politic and my work, not just in organizing, but in the world. I have had the great pleasure of being a birth worker for many years. And so this issue, this topic is very, very close and dear to me. And so we have been having conversations around reproductive health care, reproductive justice with our communities, with our networks over many years. And in particular, we've been paying attention to what we see in the news. And we've been seeing a number of viral stories in the last few weeks alone of Black women who are laboring, who are experiencing a lack of care, who are experiencing dismissal, neglect, inside of the healthcare system. And in the last few weeks alone, we saw footage of Mercedes Wells being wheeled out of the hospital just 12 minutes before delivering her baby in her car. We saw Kiara Jones, now a mother of 3, be interrogated in the triage instead of being taken straight to labor and delivery just to deliver her son 8 minutes within 8 minutes of being admitted. We saw the story of baby Amariah, whose mother was on the induction list because of preeclampsia, but was turned away repeatedly by her hospital. When she went to a different hospital reporting the same symptoms she'd previously reported, they immediately admitted her for an emergency C-section. Her baby was born with hypoxic ischemic encephalopathy, a brain injury caused by delayed care and medical negligence. And we saw the story of Tierra Walker, the mother of a 14-year-old who had also delivered stillborn twins due to preeclampsia in a previous pregnancy. When she reported seizures and dangerously high blood pressure and asked for an abortion, the only way to save her life with such severe preeclampsia at 19 weeks pregnant, Texas doctors told her there was nothing wrong with her pregnancy, just her health. Her 14-year-old son found her dead of preeclampsia in their home. None of these stories had to happen this way. Every single negative outcome was entirely preventable. But Black women are regularly and systemically ignored and disregarded to the detriment of their health, the safety of their pregnancies, and the lives of their babies and themselves. Tonight, we're talking about the Black maternal health care crisis. And we're fortunate to have incredible guests sharing their insights and taking action to save Black mothers' lives. So we're going to start with upcoming legislation with Congresswoman Robin Kelly. Then will be followed by an overview of the state of Black maternal care with Kiara M. Bridges, who you might remember from her expert handling of Senator Josh Hawley in a Senate hearing on abortion rights. And we'll also hear what organizers are doing on the ground from Angela Aina, Executive Director of Black Mamas Matter Alliance. And of course, you'll learn how to plug into this life-saving work. Finally, I ask you again to drop your questions in the chat because, of course, at the end, we will have space and time to answer as many of them as we can. So now, without further ado, we're excited to jump into the program with our first speaker. Please welcome Representative Robin Kelly.
So much, Tamika. Thank you for doing this. A shout out to the nurses. I know you're a mighty profession, despite what other people might say. And also, it's an honor to be with Black Mamas Matter Alliance. We work with them in my congressional office. Mercedes Wells is my constituent. And as was said, she was coming from Michigan. She went into labor, went into a hospital, and she was discharged from that hospital, and a little bit later had her husband delivered her baby in a truck, and then they went to a community hospital to get further care. Her strength to speak out about her experience propelled me to introduce new legislation. They contacted me because I've been working on this topic for like the last 9 years. It was my legislation that extended the Medicaid postpartum period from 60 days to a year, and we've done some other things. So when I came back to DC, we started working on the Wells Act, the Women Expansion for Labor and Labor Safety Act, because we want to make sure what happened to Mercedes doesn't happen again. And we are clear that what happened to Mercedes is not an isolated incident, as you just heard, but the bill aims to address systemic issues around maternal care, racial disparities, and hospital accountability. The Wells Act urges any hospital that provides obstetric, emergency, or labor and delivery services to develop and implement a safe discharge labor plan. The plan must at least have these elements: clinical justification for discharge, an assessment of travel distance and time, verification of reliable transportation, identification of a backup hospital or birthing facility, and documentation that the patient understands and agrees why they're being discharged. From Mercedes' experience, none of these elements existed. She was discharged with no clinical basis, no thought as to where she would go afterwards, and certainly with no patient understanding. The act also includes racial bias training for healthcare professionals, and it builds on my Maternal Health Quality Improvement Act of 2022. And I know it's not just a one shot diversity training and everybody's okay. This has to be an ongoing culture, whether in a hospital or a birthing center. And it also urge HHS to publish an annual public report, set minimum performance milestones, and fund a multi-center implementation science initiative to evaluate different training models, and also develop an interagency maternal health dashboard. So that's the Wells Act in itself. Mercedes and her husband are hanging in there. She did have to go back to the hospital, and the baby was doing okay, but then we just heard that the baby had some seizures. So very concerned. I'll be talking to them again tomorrow. But I'll stop there and answer any questions or any suggestions.
Congresswoman Kelly, would love to hear how folks can show their support for the Wells Act, how folks can show their support for Mercedes and her family.
Well, for the Wells Act, we would like to have as many endorsements as possible when the bill is filed. My office, Michelle Galdamez, is my senior policy healthcare advisor, and you can call the office 202-225-0773, or you can text her at michelle.galdamez, GALDAMEZ, at mail.house.gov, and let us know. And as far as Mercedes and Leon, um, I think she told me that she feels like God wants her to be a vehicle for change. And I mean, she makes me want to cry, and that's what she's most interested in. So just, supporting this bill and her seeing the changes, I think, that's what they want to happen. Even though lawyers contacted me, they haven't talked about any suing, or anything like that. And that's what she told me. That's for her right now. That's the most important thing, just to be, a vehicle for change and God to use her in that way. But I'm a caller, so I'm gonna
How are
give
you?
her all your well wishes and love and check.
Please, please. How are you seeing, or what kind of support are you seeing thus far in Congress, in the governmental infrastructure for the Wells Act and for other bills? Like we know, Black Mamas Matter Alliance has been in front of
Right.
Congress previously, trying to fight for Black maternal mortality
Oh,
programs.
they
So I'm
helped
curious what
us.
you're finding.
Black Mamas Alliance helped us. As we developed the things that we did, I have smart people in my office, but we reached out to the people that have gone through this, survivors, husband. We work with Charles Johnson, Allison Felix, Tatiana Ali gave testimony. As you know, it doesn't matter how much money you have or
Mhm.
how educated you are. It happens to Black women more. So just we need support with the bill, but a lot of people have come up to me, members of Congress. They are appalled, that this has happened. I'm the co-chair of a bipartisan maternal health caucus, so I hope to have some Republicans, on the bill too. We're all moms, and too many women die. Period. It's just that many more Black women die, and I know we say 3-1, but it depends on where you live. I represent the Chicagoland area, and it's more than 3-1 there. So that's just
Mhm.
the,
Mhm.
as you know, I don't have to tell you the average.
Yeah,
That's
and I live in Georgia, and of course we have one of the highest maternal mortality rates in the country. And one of the issues that we're seeing really is the loss of funding and support for, especially in rural hospitals, and the loss of sort of labor and delivery wards across the state. And I'm just very curious about, one, if there's other legislation that people should be paying attention to about around this issue, and also if what you might see, especially the vote around the Affordable Care Act today, if there are things that that may not be obviously or directly sort of connected, but that will impact this issue.
Well, one thing is over in the United States, half the counties live in health deserts, and there's maternal health deserts. My district is urban, suburban, and rural. I have Chicago to the center of Illinois. I have 4,500 farms, and actually, because of the big ugly bill, that rural areas will suffer more. And as you said, even where I live in the burbs, they're not delivering babies. They're sending us to other hospitals, and birthing centers, in the hospital are closing down. So,
Mhm.
and it's scary because, we can't claw back that bill. I hate to get too political, but if we don't win November 2026, that bill is going to go more into effect after. They think they're fooling people, but if
Mhm.
we win, then we can make some changes and amendments and those kind of things. And we're hoping now even that we can find legislation to extend the Affordable Care Act. But you're right, hospitals will close, birthing centers, will close. And the thing is, and I know your callers or participants do, we just need people to keep speaking up, that they cannot get weary, they cannot get lost in the chaos. That's what they want you to do, that you have to keep speaking up. And particularly if you have members that are in red areas, we
Mhm.
need you to speak up over and over and over again. The last election scared them. I mean, heck, Georgia won a seat back, just the other night. We won in Mississippi,
Yep.
in Pennsylvania, the first female mayor in Miami in 30 years, the first Democrat in 30 years, first female ever. So we see some changes coming, but we need people to keep marching, keep speaking up, keep making your voices heard, and particularly if you are represented by a Republican.
Absolutely. Thank you so much. Before you go, one, I want to let people know, I see the question about if you will get contact information. And yes, after the call, we will, if you register for the call, we'll make sure you should get it in your email, but we'll definitely drop it in the chat as well, so that you can get the email that Congresswoman Kelly shared, so you can reach out in support of the bill.
And I just want to, my door is always open to you guys. So never hesitate. This is such a severe, severe issue. March of Dimes just put out a report: 669 women about die every year in the richest country in the history of the world, and 20,000 babies die before their first birthday. And, most of them look like us, so it's really, really
Mm-hmm.
important. And again, we don't have all the ideas. Do not hesitate to call us for suggestions or comments or anything like that. So thank you guys so much again. Appreciate you.
Thank you. Thank you so much, Congresswoman.
Bye bye.
All right. So next up, we are excited to welcome Kiara M. Bridges, a professor of law at UC Berkeley School of Law. She is an internationally recognized expert on the intersection of race, class, and reproductive rights. Her scholarship has appeared in the flagship law reviews at Harvard, Yale, Stanford, Columbia, NYU, UVA, UC Berkeley. She is also the author of 3 books: Reproducing Race, an ethnography of pregnancy as a site of racialization, The Poverty of Privacy Rights, and Critical Race Theory, a primer. Her 4th book, Expecting Inequity: How the Maternal Healthcare Crisis Affects Even the Wealthiest Black Americans, will be published by MIT Press in March 2026 and is available for pre-order now. Welcome, everybody. Please show a warm welcome to Dr. Bridges.
Hello. Thank you so much for having me. Thanks for organizing this Women's March, and thanks to everybody who tuned in tonight and was so willing to spend your time talking about an incredibly important, timely issue. And so I'm just going to spend about 10 minutes or so just providing kind of an overview of Black maternal health care and healthcare outcomes in the US today. So we're here because Black people experience significantly higher rates of maternal mortality and morbidity than white people. We might even know the statistics, right? Black people die 3 to 4 times as frequently than their white counterparts from pregnancy-related causes. And it's important for us to understand that there's nothing new about this racial disparity. This racial disparity in maternal mortality has persisted across generations. Indeed, the gap has actually widened. About 80 years ago, Black people were only twice as likely to die on the path to motherhood as their white counterparts. 30 years ago, Black people were 3 times as likely as their white counterparts to die from a pregnancy-related cause. And today, Black people are close to 4 times as likely to die from a pregnancy-related cause as their white counterparts. And as appalling as this is, it's not even the entire story. A fuller picture of Black maternal health in the United States reveals that racial disparities in maternal mortality persist across income levels and socioeconomic statuses. And just to put it plainly, that means that poor Black people die from pregnancy-related causes more frequently than poor white people. Middle-class Black people die more frequently from pregnancy-related causes than middle-class white people. And high-income Black people die more frequently from pregnancy-related causes than high-income white people. So in other words, the higher rates of Black maternal deaths in the US are not due to Black people's higher rates of poverty, which we all know compromise the health of those who are forced to live it. Instead, Black people's higher rates of maternal deaths than white people across all income levels means that these racial disparities are not a problem of class, they are a problem of race, and they're a problem of racism, to be precise. I want to note that severe maternal morbidity is also a tragedy in this nation. Severe maternal morbidity refers to cases in which a pregnant or recently postpartum person faces a life-threatening diagnosis and must undergo a life-saving medical procedure, like a hysterectomy or a blood transfusion or mechanical ventilation, in order to avoid death. For every maternal death in this country, there are close to 100 cases of severe maternal morbidity. And as with maternal mortality, there are racial disparities in rates of severe maternal morbidity. Presently, Black people are twice as likely as their white counterparts to suffer a case of severe maternal morbidity. Now, there are many, many, many different contributors to racial disparities in maternal mortality and morbidity. I do not have time to talk about all of them, but there are a contributor is different care on the individual level. And we talk about this a lot when we talk about implicit biases or explicit biases that compromise the care that providers give to their patients of color. We can also talk about differences of care on the systems level. In the US, we have racial segregation in hospitals. There is a thing in the literature, they call it high Black serving hospitals. These are hospitals that serve high proportions of Black people. And predictably, these hospitals compromise the quality of care for everybody who delivers in it. White, Black, Asian, Latina, all of them. But because higher numbers of or higher rates of Black people delivering in these hospitals, those high Black serving hospitals with those poor outcomes with respect to maternal health tends to be disproportionately affect Black folks and tends to be a racial justice issue. Other contributors, again, no time to get into it, epigenetics, which is the expression of the gene, not the genetic makeup, but rather the way the gene is expressed as a result of environmental sort of conditions, stress and weathering, et cetera, et cetera. So I don't have time to get into all of these contributors today. What I do want to do is spend the last couple of minutes that I have with you to talk about 2 contributors to racial disparities in health and racial disparities in maternal mortality and morbidity that are simply mythical. These are contributors that folks who are defenders of the status quo, folks on the political right will try to offer as explanations of why Black people find it so much harder to survive pregnancy, childbirth, and the postpartum period. And these 2 mythical contributors to racial disparities in health and racial disparities in maternal mortality and morbidity are genes and culture. These are mythical contributors to racial disparities in health. Let me start with genes. There is no race-specific genetic variation that predisposes Black people to all manner of death. It just doesn't exist. They've been looking for this race-specific genetic variation since we found out that genes exist, and they have not been able to find it because it does not exist. The empirical research simply does not support the claim that Black people have higher rates of maternal mortality and morbidity, or higher rates of just morbidity and mortality across all measures because of some gene that kills Black people. Dorothy Roberts, who's one of the foremothers of the reproductive justice movement, she has put it so powerfully. She says, quote, "It is implausible that one race of people evolved to have a genetic predisposition to heart failure, hypertension, infant mortality, maternal mortality, diabetes, and asthma. There is no evolutionary theory that can explain why African ancestry would be genetically prone to practically every major common illness." And I think it's important for us to disabuse ourselves and others of the notion that race-specific genetic variation is killing Black people, because when we suggest that Black people have higher rates of maternal mortality and morbidity than their non-Black counterparts, when we suggest that this is because there's some gene that's killing us, that's a distraction. It's a distraction from actually addressing the factors that are, in fact, killing Black people. Again, Roberts puts this so powerfully. She says, quote, "Researchers still do not know why Blacks get and die from heart failure at a much earlier age than whites. But if I were a scientist, I would start looking at the effects of young Black men's 75% chance of being incarcerated in some cities. Heart disease researchers should be more interested in the fact that Black men are 7 times more likely than whites to be in prison in this country than the less significant genetic differences many are so fixated on." Again, genes, a mythical contributor to racial disparities in health and racial disparities in maternal mortality and morbidity specifically. The second mythical contributor that I want to talk about is culture. Defenders of the status quo will try to tell you, try to convince you that it's actually Black people's culture that is killing them, that predisposes them to death. And it is, of course, true that one's health behaviors affect one's health outcomes. So if you eat fatty, high sodium foods, if you drink sugary beverages, if you smoke cigarettes, if you don't exercise, that's going to compromise your health. But the undeniable truth that unhealthy behaviors lead to unhealthy outcomes becomes much more problematic when unhealthy behaviors are imagined to constitute a culture that explains racial disparities in health. You hear these cultural explanations often, actually. There's that Tuskegee explanation of Black death, right? The idea is that, well, the Tuskegee experiment kind of created this culture of distrust in Black people that kind of counsels them not to go to the doctor, which of course compromises their health. You hear these cultural explanations of Black death when people say, oh, Black people just have a culture of like not exercising and like eating like fatty foods and stuff. And that's kind of what explains their higher rates of hypertension and diabetes and et cetera. It is so myopic to argue that when people of color engage in unhealthy behaviors, it is because their culture made them do it. And it's myopic because the reality is that oftentimes the lives of people of color have been constrained in ways that make unhealthy behaviors the only option. In other words, the health behaviors of people of color are not cultural. If people do not go to the doctor as often as they should, it is probably because they are uninsured or underinsured, or there are no health providers accessible to them. And we also don't have to explain this distrust of medical authority on the Tuskegee experiment, which ended 50 years ago. We can explain distrust of medical authority on things that happen today. If Mercedes Wells distrusts going to the doctor, we don't have to talk about what happened in 1972. We could talk about her being wheeled out of the hospital 12 minutes before she gave birth to her child. If people of color eat foods that are high in fat, sugar, sodium, et cetera, it is probably because those foods are the only affordable option available to them in their neighborhoods. And so I wanna wind down, but I want the takeaway from my talk to be that maternal deaths are preventable. Most maternal deaths Most cases of severe maternal morbidity shouldn't be understood as this like inevitable sort of byproduct of being pregnant. Instead, the US's embarrassingly high maternal mortality and morbidity rates are a product of the US failing to take care of people who can become pregnant in this country. And I'm going to end by saying it is reasonable to expect that things are only going to get worse when it comes to maternal morbidity and mortality in this country. And its slashing of the size of the federal workforce and in its gutting of the administrative state, the Trump administration has shown no particular solicitude for agencies and departments whose charge is to make it so that Americans can emerge from pregnancy and childbirth alive and unscathed. Earlier this year, the Centers for Disease Control's Division of Reproductive Health, which monitors maternal mortality, was shuttered amid mass layoffs and a restructuring of the agency. So we have a lot of work in front of us. We got to vote. We got to vote, y'all. I'll stop right there.
Thank you so much, Kiara. I was over here snapping along to so many of the points. I'm just very grateful for all of your work and all of your research. If you have questions for Dr. Bridges, please put them in the chat. I see a few questions in here after the next presentation. Then we're going to bring folks back and we're going to have some good Q&A and good convo. So next up, I just want to welcome our last presenter this evening, Angela Aina, who I have had the great pleasure of witnessing and being in space with over many years. Angela is the executive director of Black Mamas Matter Alliance, and she's a co-founder and executive director. Excuse me. Let me be precise. A network of Black women-led organizations advancing Black maternal health, rights, and justice through policy, research, culture shift, and leadership development. A catalytic architect of the Black maternal health movement, Angela is a award-recognized public health practitioner with over 19 years of experience in maternal health program development, evaluation, strategic planning, and advocacy. Since BMMA's inception in 2016, Angela has led the organization in raising more than $2 million annually, creating jobs and fellowships, and expanding a national workforce rooted in birth and reproductive justice. Her public health career spans the academic, nonprofit, and government sectors, including over 5 years at the CDC, where she served as a public health analyst, health communication specialist, and public health prevention service fellow. She holds a Master of Public Health Studies in International and Women's Health from Morehouse School of Medicine, a Bachelor of Science in Psychology and African American Studies from Georgia State, and is currently completing her Doctor of Public Health. I think completed at this point. We're gonna see what she said. All right, please welcome Angela to our program. Oh, Angela, can you hear us? Your mic is muted. Can you see that? Should be right at the top of your icon.
I was
There we go.
talking, and you can hear me now? Awesome. Let me go ahead and get started. As I was saying, just really glad to be here. I want to thank Congresswoman Robin Kelly, and also thank Dr. Bridges, and also thank you, Tamika, and everybody at the Women's March for taking the time out to talk about these issues. And let me get right into it. What I want to do is really hone in on the solutions and the great work that I am fortunate enough to be a part of over hundreds and hundreds of Black women organizers, leaders, doulas, midwives, physicians who are organizing, who have been organizing, and who have led the charge in care innovation, in research, in policy, and culture shift work for many decades, and have helped to usher in, along with myself, as being the founders and leaders of the Black maternal health rights and justice movement. We are BMMA. We are a network of Black women-led orgs and multidisciplinary professionals, as I've said, who ensure that all Black mamas have the rights, resources, and respect to thrive before, during, and after pregnancy. BMMA honors the work and historical contributions of Black women's leadership within their communities, and this is within our communities all across the diaspora, and values the need to amplify this work on a national and global scale. And so for this reason, we don't have chapters. We are composed of existing organizations and individuals whose work is deeply rooted in birth, reproductive justice, and the human rights framework. Think of BMMA as the premier Black maternal health professional organization, and we focus on building the skills, convening, and mobilizing the global Black perinatal, maternal, and reproductive health workforce to end maternal and infant mortality. Through these goals, we work to change policy, cultivate research, and that research is genuinely rooted in community-based participatory research and Black scholarship. We work to advance care, in particular, high quality, evidence-based, full spectrum, holistic care, and to shift culture, because we have to continue the work, as you heard from Dr. Bridges, about those mythological contributors that, people who are pushing disinformation. We have to continue the work of pushing back on the negative narratives and stereotypes of Black motherhood and our bodies. Of particular note, I need to lift up that here at BMMA, one of the innovative things that we did when we got started was to first define terms. When we say Black mamas, that represents our full diversity of our lived experience. That includes birthing people, whether they're cis women, cisgender women, trans folks, gender expansive and gender nonconforming individuals that are all people of African descent across the diaspora. We recognize, celebrate, and support those who care for and mother our communities, whether they have given birth or not. So believe it or not, if you're like me, you're auntie, an eldest daughter, you've had to serve in these roles before. Again, you are a Black mama, right? We stand in solidarity with all Black mamas. As mentioned before, we are the crisis. The crisis is not Blackness. The crisis is not maternal. The crisis is not the desire to start your family. The crisis is in the Americans' system of terrible healthcare. That is the crisis. We are in a maternal healthcare crisis, and we are in today still seeing a significant disinvestment in maternity care and reproductive health care across the nation that is dire for everyone. What has recently came out of the CDC report in 2023 has found that even while there has been a slight decrease in the maternal mortality rate across other ethnic groups, Black women's maternal mortality rate, even though there has been exceptional maternal health legislation that has been introduced at the federal and state level since 2018, our rate has not even made a dent, which lets you know that these issues that's impacting the maternal and infant mortality rate is systemic. It's not our Blackness. But the other thing that is jarring is that all these deaths, a huge proportion of these deaths, over 80% of pregnancy-related deaths, are preventable, meaning that there are solutions, and we do need to do more and to advocate more for a multitude of solutions. The other thing, like what we heard Congresswoman Robin Kelly mentioned earlier, and I'm so glad she lifted this up, just the rate of our infant mortality rate and the disparities of the increased rate of infant death, especially among Black populations. I want to shout out the great public health folks who worked very hard, especially in the state of Mississippi, to get the state to declare a state of emergency about their infant mortality rate. That is what public health true grassroots public health work is meant to do, to sound the alarm and to say we have to do something. This slide is just showcasing to you all again just more statistics around the pervasiveness of our infant mortality, preterm birth rate, and the maternity care gaps. You know, some folks utilize the term from Marcia Dimes of maternity care deserts. Others utilize maternity disinvestment areas, which also is an impactful term to showcase how these hospital closings are intentional disinvestments. And so when we're talking about these issues, I want to lay the foundation for Black maternal health work. As Dr. Bridges had started to mention, we got to put a lot of these issues in its historical context. Let's be clear. Black folks, and especially Black women, have been organizing since day one. It is through our midwifery care work that was stolen and utilized to even create what we know today as nursing. It is through Black women's bodies, right, and the exploitation of experimentation on Black women's bodies that help to inform and create what we know as gynecology. We even know about the advancements of biomedical research that came out of Black women's cervical cancer cells with Henrietta Lacks, right? And then through understanding how we practice even lactation that was came out of Black women having to breastfeed everyone during the institution of slavery, and how our milk helped to build the immune system of America. We have to understand this history and the irony, right, of how Black women's bodies, Black women's care work, and our traditional practice around birthing and ushering in how we support the pregnant person and their families through midwifery care, wanting to lift up the granny midwives and how instrumental grand midwives were in the 1800s to help inform what eventually became medicalized as pregnancy care in hospitals. What I'm lifting up is that the fact that it's an irony that now we are still seeing maternal and infant mortality impacting the very people that they stole these practices from. Also wanting to lift up that, again, as I stated before, Black people, especially Black women, especially in this country, have always organized. We've always met the call to provide care, especially medical care, nursing care, midwifery care to our communities during Jim Crow and even during segregation. And we formed organizations like the National Medical Association, NCNW, so many health and public health care work has came out of us organizing. And so you're going to hear this organizing theme that I'm going to talk about. And here at Black Mamas Matter, I want to thank Tamika for starting us off with talking about how the importance of what are these theoretical frameworks that we practice. What are those frameworks that inform the work that we do in our organizing? At BMMA, Black maternal health, as we define it, is informed by birth justice, reproductive justice, human rights, Black feminism. I would also add Pan-Africanism, womanism, and research justice. You know, we stand on the shoulders of Mama Shafia, Loretta Ross, Dr. Fleta Match Jackson, Dr. Patricia Hill Collins, Dr. Layli Mapayam, and so many others that inform all of the work that we do. We got started in our organizing in 2014, 2015, and became officially Black Mamas Matter Alliance in 2016. And let me tell you, we boldly, with $0, went up and did the very first congressional Hill briefing in 2017 under this administration's first term to demand that there something gets done to address the maternal mortality crisis in this country. And so we held the very first Black Maternal Health and Reproductive Justice Congressional Hill briefing in 2017 in Washington, D.C., and that later sparked further momentum where we created a number of documents that then helped to inform later on the formation of the Black Maternal Health Caucus with Congresswoman Lauren Underwood and Alma Adams, and so many of our partners in the alliance and so many stakeholders, even some of you that are probably in the audience today, helped to contribute to the huge package called the Black Maternal Health Momnibus Package, which started off as a robust 11-piece legislative package to address really the social and structural determinants of maternal health, right? I'm just lifting up here that through the years, we have produced documents, reports, and platforms across policy. We have our policy agenda, issue briefs. If you're trying to understand even more particular, what are these issues across Black maternal health, what that is, and who are the folks that are doing the work to address these issues across multiple regions in the nation, go check out our literature at blackmamasmatter.org/literature. I saw some questions in the chat earlier where people were curious about what is happening. I want to really lift up that please understand there is a multitude of Black women-led organizations and doulas, midwives, physicians, and others who are doing the work and meeting the call right now to address the gaps in care. And really one of the many solutions is that we need to raise awareness and raise visibility of who we are and our resources. I'm going to skip over some of these slides really quickly. This is just showing some of our portfolio of work and how we have worked with stakeholders across hospital care and community-based organizations to implement pilot programs to ensure that we are meeting the gaps at the local level for folks who are needing that social safety net services, to implement community awareness programs. Here is just some of the highlight again of our comprehensive policy agenda that's also on our website that you can look at. We have recommendations there to that touch from issues around criminalization in pregnancy to how we need more and better programs around, for example, to support those very courageous doulas who provide doula care and work in detention and prison facilities, all the way to demanding that states introduce more comprehensive supportive policies for the expansion of midwifery care and scope of practice of midwifery care, which is also a solution, all the way to acting in for policy and legislation at the local, state, and federal levels to put more investment dollars to provide grants to community-based organizations that can do a lot more programs and services beyond the care of hospitals, but then to also further support grants and incentive programs for physicians in hospitals to do better and to lean into quality improvement programs. We also provide lots of training for our workforce. These are just photos from our conference last year during the Training Institute. And just lifting up that right now, we actually have a call for abstracts for our conference that we're bringing back in 2026. And I just want to take a moment to give a big shout out. Yes, I saw all the chat, all the nurses, our public health practitioners, our physicians, our environmental health practitioners who understand the oath that they took to do no harm, to protect human life, to improve our environmental conditions. And it's now more than ever in this very treacherous political and economic environment. We need to organize. We need to organize and get back to the health justice roots that a lot of us got started in. And we need to connect and be able to provide stronger community based networks of care, even outside of what the government can provide, because that is what it's calling us to do in this moment. I'm just lifting up ways that you can get involved with BMMA. If you want to get involved today, join our newsletter, blackmamasmatter.org/connect. Join our newsletter. There's so many ways that you can learn about what's happening with some of our partners across the nation and some of the work they're doing. But then also, we are the founders of Black Maternal Health Week. Black Maternal Health Week was started in 2018 for this very reason, not only to sound the alarm on the atrocities of how we are being treated in the healthcare system, but like I said, most importantly, to bring visibility to the solutions, that the fact that doulas exist, midwives exist. We have fantastic and phenomenal reproductive justice centered clinics that exist and that have been doing the work and that are here to support all of our families, no matter their income, for their full spectrum maternal and reproductive health care services and needs. And Black Maternal Health Week serves as an organizing opportunity for people to connect, to learn, to have to understand deeply some of these issues and the ways in which you can collaborate with Black-led organizations that are doing this work. In 2026, the theme for Black Maternal Health Week is rooted in justice and joy. So I invite you all to join us for our national call that we'll have February 27th in February 24th, 2026, where we will talk more about how folks can get engaged in Black Maternal Health Week and how you can make a difference. And of course, save the date, September 10th through 12th, 2026, for our Black Maternal Health Conference and Training Institute. We're bringing it back here in Atlanta, Georgia. And again, this is the official global assembly for all things Black maternal health work, clinical innovation, policy work, and research. So definitely save those dates. And then finally, to close out, just to bring life to everything that I'm talking about, I want to showcase to you all just a 2-minute video so you can really see the impact of this work and understand that Black maternal health is not a negative connotation. It is our birthright. Black maternal health, Black maternal liberation, Black maternal justice. Yes? So let me play
As the
this
premier
clip
Black
and I
maternal
hope
health
that you
professional
all can hear it.
organization, the Black Mamas Matter Alliance, as the premier Black maternal health professional organization, the Black Mamas Matter Alliance, or
I'm going to ask, can y'all hear the audio? Because I can't hear it.
Yeah, we can hear you. We can hear it.
as the premier Black maternal health professional organization, the Black Mamas Matter Alliance, or simply BMMA,
We hear it, Angela. We can hear it well.
Can y'all hear it?
Yeah.
Okay, because I can't hear y'all. I'm so sorry. My audio has gone out again. I'm going to try again. Let's see if it'll work.
As the premier Black maternal health professional organization, the Black Mamas Matter Alliance, or simply BMMA, champions the rights and well being of Black mamas, families, and communities. We do this by developing programs and initiatives that build skills and increase the capacity of the perinatal and reproductive health workforce. That includes physicians, nurses, midwives, doulas, and leaders of community based organizations. At BMMA, we are committed to closing the gap in access to quality, holistic, and respectful care by cultivating a strong Black maternal health workforce and driving a culture shift that amplifies the voices and experiences of Black mamas, leaders, and parents, especially through our annual Black Maternal Health Week campaign. Our work, including our biannual Black Maternal Health Conference and Training Institute, contributes directly to improved mental and physical health outcomes by supporting and training hundreds, even thousands, of maternal health professionals to deliver evidence based, culturally congruent care. We also tackle systemic injustices by advocating for maternal health equity policies at the local, state, national, and global levels. BMA's work is deeply rooted in Black feminist and womanist perspectives, but the impact of what we do extends beyond any one community. The solutions we uplift are relevant to everyone, committed to improving maternal health outcomes, dismantling inequities, and advancing systems change. Our programs are open to all and every stakeholder that's working to strengthen maternal and reproductive health, regardless of background or identity. BMMA's work is especially valuable for skill building, quality improvement, and building networks of care across local communities and the global diaspora. So join us at blackmamasmatter.org and click Get Involved to participate in this movement. Together, we can ensure that all birthing people and families, especially Black mamas, not only survive but thrive.
Again, I hope you all, even though I can't hear y'all, but I hope you can hear me. These are all the ways that you can follow us on all our social media accounts. And again, sign up for our newsletter at blackmamasmatter.org /connect. If you want to learn more about Black Maternal Health Week, that's blkmaternalhealthweek.com to learn more about that and the history behind it and how you can get involved. And then also, if you want to learn more and follow along to figure out how to come down to Atlanta, Georgia, and join us for our conference in 2026 in September, go to blackmaternalhealthconference.com. Again, thank you so much to the Women's March for having me.
Thank you all. Thank you both. Thank you both for joining us. We're going to take like 2 questions before we close out for the night. I am super grateful for the wonderful conversation. I want to pull out a couple things. It might be 3. I'm gonna see. We're gonna see where we go. The first thing I would love to ask, we had a some chat, some some comments in the chat. I would love to hear what you all would say to folks who ask, if there is a crisis broadly around maternal mortality and maternal health care in this country. If women broadly are facing misogyny, disrespect, and disregard in pregnancy and birth, why focus on Black women? And I would love to hear y'all's response to that.
When we focus on, now I can hear you. When we focus on Black women, and just in general, when we focus on people who are most marginalized by an issue, and we address those issues from policy, and structurally, how to ensure that those folks who are most impacted by said health problem or health outcome, that has a ripple effect to have a positive effect for everyone. An example of that is, think about it's the ADA, and I don't want to say the wrong name, but it's the Disability Act, the American Disability Act, the ADA. And I think the expansion of sidewalks and things of that nature, that had a significant ripple impact effect for so many people beyond folks who are disabled and needed those extension of the sidewalks and everything that the ADA, and again, not perfect, but at least what it did. So if you think about it from that perspective, it with a lot of, and that is the approach for a lot of the Omnibus Act bills, by centering the Black women and Black birthing people in how we think about policy and maternal care, and if we uplift what they need, that is going to have a positive impact for everyone else. I always like to tell people white women do not have good maternal health care. Like the floor is the our women's health care in the country is bad, and then for everybody else is in hell. Like I need for everybody to catch a clue. So that's why we need a, okay, let me stop talking, but that's why we need to center Black women. Yeah.
Sorry, I was asking if you wanted to add anything. I'm sorry.
Okay, I was like, I didn't know. I just, I will echo everything that was just said. When the most marginalized people get free, everybody gets free. And I'll just give a very specific example. Part of the reasons that was mentioned already on the call, that the labor and delivery departments are closing, right, in the hospitals all across the country. And part of the reason for that is that those labor and delivery departments rely on Medicaid funds. A lot of times, a lot of their patient population rely on Medicaid for their health care. Medicaid is reimbursed, I believe, in like a quarter of the rates at which commercial insurances are reimbursed. And so what that means is that a labor and delivery department that relies primarily on Medicaid patients, they are in the red. They are not receiving enough funds to keep them solvent, and so they close, which disproportionately impacts Black folks. Black folks disproportionately rely on Medicaid, or disproportionately impoverished. So if we're saving Black people's lives, and part of the way that we save Black people's lives is to raise Medicaid reimbursement rates so that these labor and delivery departments can stay open, so that they can stay solvent, well, that raises the Medicaid reimbursement rates for everybody. So everybody now will be able to access the care that they need with their health insurance, Medicaid. So again, if we get the most marginalized folks free, everybody gets free.
Thank you. Thank you. I want to smash a couple questions together here. Folks want to know, this is such a large systemic problem. And what can everyday folks, what can activists do if they care about this issue? How can they, what can they do to help educate other folks? And what can they do to sort of take action and sort of chip away at such a big systemic problem?
I'll start, and then I'll let you finish. and I'll start just by saying that I actually, as I mentioned in my presentation, the problem of racial disparities in maternal mortality and morbidity, and racial disparities in health just generally, is like multifactorial, right? There are many different contributors, and I actually think that is a wonderful characteristic of the problem, because it means that there are many different places into which we could intervene, right? If it was just like one thing that was causing this problem, and it was this one guy who had one phone that you needed to call, and you needed to get that guy on the phone, right? Then like the stakes would be incredibly, high. Like, how are we going to reach that guy? But in fact, there are like about 7 different factors that contribute to racial disparities and maternal mortality and morbidity, and we can all be pressing on different factors. And so I see some, in the chat, there's a comment that is kind of focusing on differential care that Black folks are receiving, right? And so that can be the button that we press on. Some organizations might press on that button. So they might be interested in implicit bias training. They might be interested in establishing, in California, we have safety bundles, right? And so these are these protocols that hospitals have to comply with. So for example, if a person is in a hospital hospital and their blood pressure is 140 over 90 or higher, you're not letting them go, right? So it's removing discretion from maternal care so as to remove the disparities in care, right? So we might press on the button of individual contributors. There are systemic contributors, right? We need to integrate these hospitals. We need to make it so that it is unimaginable to imagine a Black serving hospital, right? In a country in which the Equal Protection Clause is in the Constitution, we're supposed to have equality for all. Nevertheless, we have these very unequal institutions, right? So we need to integrate our institutions. We could talk about doula care. Let's reimburse doulas at an adequate level. We could talk about midwifery care. Let's not approach pregnancy necessarily as a dangerous condition that needs medical management, but perhaps the natural state of the body when it is in fact healthy for a person to be pregnant. Again, so there are many different things that we can press, and I'll just stop there and I'll let Angela continue.
Yeah. So the ways in which the everyday person can get engaged and help to join to make a change is number one, like I said, follow us and engage with us for Black Maternal Health Week. That's what it was created for. It is a very successful public health awareness campaign. And it's just as simple as number one, you heard from Congresswoman Kelly earlier. Contact their office, get behind a positive bill, call your representatives locally, ask them, what are you doing to help address maternal health and infant health and child health care in our local area or in our state? We have to apply the pressure on the very policymakers who are making these decisions on our day-to-day lives. And then also, most importantly, I promise you, for a lot of you who are working in a healthcare system, or even if you provide general social work services or programs or social safety net care to everyday clients, I promise you there's probably a community-based organization that's not that far from where you are providing services. Get to know your local birth justice and reproductive justice organization and support them. Contact them, volunteer with them. You know, like so many other nonprofit organizations and other health agencies that have been impacted by, you know, the defunding of public health funds. You know, so many of these same organizations are hurting right now, but they have always been the ones to stand in the gap of care. This is what I mean by those of us that have had this calling to be a nurse, to be a physician, to just provide health care, that we have to get back to that roots of community care. And that is volunteering, going out and engaging and partnering with these organizations, because they probably already have programs, services, food banks, you know, providing diapers, clothing to folks. There are ways in which you can be of service to these organizations that are already doing the work. And I cannot overemphasize, I don't even know what the word is, but I just want to scream at the top of my lungs. This is the time more than ever, especially at the local levels. Yes, I'm gonna sound like a soundbite. You gotta vote. I don't like, no matter how you feel about that, no matter how you feel about that, this is the time that we cannot hand over our basic human rights and what is due to us. And so it is important to, at the very least, vote.
Thank y'all so much. Whenever I'm having a conversation about Black folks in birth work and Black folks in birth broadly, I'm always, saying that Black folks have been resisting the control over Black folks' reproductive capacity since the moment we stepped on these shores. And I am just so grateful for the work y'all are doing inside of that lineage, inside of that legacy. And I just want to thank y'all again so much for joining us tonight. And if you register for this call, we will send all the links. We know we got a gang of links for y'all, some email addresses for y'all. We will share more information, everybody's website Go follow everybody on social media. So you will have all of that afterwards. If you want to watch the replay, you want to share this with your friends, it will live on our Facebook, it will live on our YouTube, it will live on our Twitter. So please go share it out with the world. Please take some kind of action. We cannot, win this thing. We cannot fight for reproductive rights broadly without understanding this question. We cannot fight for access to abortion care without understanding this question. We cannot call ourselves feminists without understanding this question. And so I need you all to be in the battle and to be in this fight. Thank y'all again. Thank you everybody who joined us. Thank you again to Angela. Thank you again to Kiara. Thank you again to Representative Kelly. And y'all, everybody have a wonderful night. Good night, y'all.